Okay, hello, welcome, good evening everyone. We are very excited to be having a evening with Sharon Tilley and a practitioner seminar for you this evening about using laser therapy to manage lymphedema. So I am going to just wait while our participants come in, and at the moment I'm going to say a few things. I'll just like to share my screen and just start from here, from the beginning, slideshow from the beginning. Okay. Oh, where's my picture? Okay, that's not a problem. So welcome everyone. And this is our seminar this evening. My name is Catherine Norton. I'm just going to take a few minutes to introduce the evening while everyone arrives. I'm the CEO of Heal with Laser, and I have healthcare experience in management, looking after patients as well as business systems. We've been running this practitioner webinar series since the early part of this year, and this is the last public webinar that we're having for 2020. We will have an MLS owners webinar on the 26th of November. So for those MLS owners, we'll be doing a focused Q&A session. And we're going to continue our series into 2021 because it's been such a great success and we continue to get really great feedback from everyone. So if you can, down the bottom, there's a Q&A, questions that you can put into the chat box. If you write any questions in, we will take some time at the end to answer these. After this webinar tonight, we'll be sending out the audio only, and as a follow-up that'll be available for a short time afterwards. There's also a feedback survey at the end of our webinar if you can help us out with any comments that you have. We're going to be talking about a lot of different kinds of lasers and laser therapy in general tonight, but the MLS laser that will also be part of the conversation is a new way of doing business. It helps you grow your business by offering new services and acquiring new patients. As we'll see tonight, it can help improve clinical results, enhance your reputation, and most importantly, can help your patients get better and faster. MLS laser is steeped in research. They don't just build lasers, they study lasers, they research lasers, and are constantly developing protocols in conjunction with the research. So that totally informs the laser. Now, our guest speaker tonight is Sharon Tilley, who is a physiotherapist based in Adelaide in Australia. And I had the very good fortune of meeting Sharon some years ago up in Darwin at a lymphedema conference. And I was very new to laser, and I learned so much from Sharon, who is one of the most generous people with her knowledge and sharing her ideas. So Sharon's going to be speaking to us tonight about using laser therapy to manage lymphedema. And she's also going to be talking generally about laser and a bit of background for those of you who may be interested in that. So she's the principal physiotherapist at Lymphoedema and Laser Therapy in Adelaide. She's worked at Flinders University on joint research programs, and she purchased her first laser in 1989, and now she has 11. She's very committed to helping the medical community. She's a committee member of AMPA, which we talk about often on these webinars, the Australian Medical Photobiomodulation Association. And she's also a member of ALA, the Australasian Lymphedema Lymphology Association. So I'm going to now turn it over to Sharon. We've got most everyone in the meeting now. Can I just say we have got many people from Australia, but we also have people from the UK, from the USA, New Zealand, but to special mention, we have people from Slovenia, Thailand, South Africa, Taiwan, Malta, and China. So it's certainly a global experience. So I'm going to stop sharing my screen now and put it over to Sharon and say, welcome, Sharon. So good to see you again. And, I know everyone's going to enjoy listening to you. So thanks so much.
Thank you, Catherine. I will just share my screen with you and hope this works seamlessly. I think we're right to go. It's wonderful that we can all meet together in different platforms. That's one good thing, I suppose, that COVID has shown us, that we can't keep a good therapist down. So strap yourself in. We're going to do a very quick 45-minute session on using low-level laser, which is now called photobiomodulation, in the management of lymphedema. Now, I know there are some of my colleagues out there, lymphedema-trained therapists, but we also have some therapists who perhaps haven't had a lot of experience with lymphedema. So I'm just going to quickly go through, oh no, sorry, it looks like my, I'm going to just, sorry, get out of there because it looks like it's not loading on properly. Right, I think that might be better. So what sort of conditions do we see in our clinic? It's an evolving list, but these are just some of the common conditions that we see. Really tonight I'm just going to be touching on lymphedema. We just simply don't have time to mention these other conditions, but I wanted you to get a sense that we are using lymphedema in a very broad range of conditions related to cancer management and rehabilitation, but also just for general musculoskeletal issues that perhaps people are wanting to have help with lasers. So there's even some early research around using it for peripheral neuropathy, chemo-induced peripheral neuropathy. Not a lot, but we're starting to have that conversation as well. And I will finish off at the end of our webinar just mentioning the compelling research around oral mucositis and radiation dermatitis, which I think will be something that we'll certainly see more of in the next 12 months or so. So just a little introduction into lymphedema, and I'm sure we would all be able to go back to our basic physiology and recall that Starling's law is something that's mentioned when we're talking about hydrostatic forces and osmotic forces in capillary beds. And you may well remember that Starling's law really stated that there was a net filtrate into the tissue space from the artery into the tissue space, and then had to be reabsorbed back into the vein. And that was just through the process of the difference in osmotic and hydrostatic forces within the vessels and the tissues. But we've really come to understand, and we talk now about a revised Starling law, and that really now states that there is a net filtrate into the tissue space from both the artery and the vein, and that it's not absorbed at the venous end. In fact, the lymphatic system is solely responsible for the absorption of that fluid. So we've now come to understand that the lymphatic system is a very crucial element in that, in those fluid forces and establishing a balance between the fluid in the vessel and in the interstitial space. So it's now a revised Starling law. So the lymphatic system is a very complex form of superficial joining the deep, superficial system joining the deep system underneath into the muscle, more underneath the muscle. So really with our laser, we're having an influence on the superficial lymphatic system. So you can see here, this diagram is basically the network, the deep network. We can't show, of course, all the little superficial, the tiny little superficial capillaries. But what happens is that the superficial capillaries drain into the deeper system through collaterals, and then eventually into at the venous angle on the right and the left side near the heart, at the angle between the subclavian and internal jugular. So the right upper limb, the right side of the face and neck, and the drain to the right lymphatic duct, and then the left arm, legs, and the left side of the thorax and head drain into the thoracic duct on the left. The lymphatic system is broken up into territories, and these are important when we start talking about manual lymphatic drainage, which I know some of you would be practicing. But what happens, and of course these systems might differ slightly between individuals, and that's because our anatomy actually varies quite a lot. Even the number of lymph nodes that we have in our armpit can vary by up to 40 or 50 lymph nodes. But in the simplest term, we can say that the lymphatic territories in our trunk and upper limb are broken up into 6 different regions. And what happens is sometimes one region becomes quite congested and clogged. And with our massage, we move that clogged area into another area that isn't quite as congested, and then it can drop, that fluid can drop into the deeper system, and then eventually, as I said, get absorbed back near the venous angle. So that's what our upper limb looks like, and our lower limb is similar. There are 3 major territories in the leg. So I've just put those slides in because it's helpful to understand why we're putting the laser where we are, and I'll come to that when we start talking about protocols. Now, a very exciting area that's been evolving in our lymphedema world is the use of indocyanin green dye to look at the superficial lymphatic system. So this is a green dye, quite safe. It's been used in other forms of medicine for quite some time. It's injected intradermally, and then an infrared camera can trace where the lymph vessels are. So these lymph vessels that you see on your screen are fluorescent, is the fluorescent dye that's taken up with the camera. And it's become very evident to us that lymphatic pathways are, as I said, quite different in even your right and your left side. They can be different. But it's really helped to inform us as therapists where the lymphatic vessels go and where we need to concentrate our treatment and perhaps access pathways that we didn't know existed, or that might become dominant when other pathways are shut down through surgery. So the interstitial fluid volume really depends on many, many different aspects, and I've just included some of those there for you. But in essence, we're only really using about 10% of our lymphatic capacity at any one time. And our lymph system can increase tenfold for short periods of time when it needs to. And that might be when downstream there is an increased fluid volume and the lymphatics have to clear it quickly. It might be in times of infection or inflammatory response where there's more interstitial fluid. Because really our lymph system's quite slow. It only really drains about 100 mils per day out of an arm, for example. But if any of these factors that you can see up on the screen changes, then of course it has an influence on the lymph load in our interstitial tissues, which then means our lymph system has to up the ante to cope. So just to explain that in a different format, you can see on this graph on the left, what happens is that in a low protein edema, you can see the line there fairly static, and then all of a sudden there's an increased lymph load through trauma or injury or inflammation. And then our lymph transport system, that blue line above it, increases to cope with that increased lymph load. And then as the lymph edema resolves, our lymph system settles down, if you like, and it doesn't have to work quite as hard. And if we compare that to the graph on the right, which is an example of what happens in high protein edema, which is, of course, what happens with lymphedema, that's the difference between lymphedema and edema, is that our lymph system on the bottom, our lymph load increases, but what happens in that blue line is the lymph transport capacity has reduced, largely through the lymph system being disrupted, and that might be through surgery or radiation, to the point where it can't clear that excess fluid load, and then we develop, the balance is tipped, if you like, and we get this high protein edema. So I've got an example here of what happens. It's a lovely little animation taken from a video produced at Flinders, and you can just see that's the initial lymphatic with all the little filaments that open up the mouth of the lymph vessel. And when it's a lymph vessel in the initial system, it's a single cell system, and it becomes muscular more as it gets into the deeper system. So this is just showing you how it becomes a deeper system, more muscular, more robust vessels. And then the lymph eventually is joined by, you can see lots of collateral pathways there. So it's a real network of vessels, a very a complex network of vessels that do largely follow the veins. And then, of course, you can see there it's draining into a lymph node. So when there's surgery and disruption of lymphatics, you can see here an example of what happens. The lymph can go to a different pathway. It can get taken up by a collateral pathway. Now, sometimes this will work for some time, but then, of course, what happens over time is the lymph vessel gets overloaded, swollen, the valves fail, and that lymph vessel just can't cope anymore. And then we see an example of lymphedema manifested quite obviously when we measure limbs. Now, this little video here is a normal uptake of lymphatics, and you can see there that everything's working quite nicely. The lymph vessel's pumping away, excess protein and fluid is going into that vessel, and the little filaments there are, when they're stretched is what opens up the lymph mouth of the lymph vessel. Now, if we look compared to this one, you can see there what's happening is that it's a very congested area. There's more fibrosis in the tissue space, and the little protein and debris molecules are trapped in the fibrosis, and the uptake is reduced into the lymph vessel. So it's building up into the tissue space. Okay. So there are clinical stages of lymphedema. We won't spend a lot of time on this, but it might inform us about how we use the laser. Perhaps in the latent stage, which is a very early stage, we may not see much lymph in the arm or leg or head and neck, but it's there, and we can measure it with very sensitive tools that lymphedema therapists often will use now. And then obviously as it progresses, it goes into a stage 1, 2 and 3, and the levels of fibrosis are different in those levels. So what can happen is that our laser perhaps is more relevant where there's a lot of fibrosis. We may need to use our laser more regularly on those fibrotic areas. In the latent phase, we might be using it just to mitigate some inflammatory response early on in the vessels. So it may change as lymphedema progresses. So this is just a picture of a stage 2 lymphedema to show you what it looks like for those that perhaps may not have seen it before. I've just put this slide in because you can see in the stage 3 lymphedema, the skin does become quite different. There's papillomas, there's a warty consistency to the tissue, there's hyperkeratosis, and there may be leakage of lymph even through the skin. And that redness is not an infection, it's actually a low-grade inflammatory response. It's not cellulitis, which we might jump to conclusions and think, but it's a bilateral inflammatory process. And the laser can help change some of those things. We believe we may even be able to reduce the incidence of cellulitis, which you may well know is a real risk when we have lymphedema. So that's really what a stage 3 lymphedema looks like. So factors that will increase lymphatic function, and some of these are not relevant necessarily to our treatment we're using laser, but anything that increases the skin tension or increases the compression in tissues, and that's why we use garments, will help to increase the uptake of fluid. So external compression is a very important part of what we do as lymphedema therapists. Direct stimulation of the smooth muscle in the larger vessels, and I think this is one reason why laser can be useful, because we increase the pump rate of the lymph vessel through direct stimulation of the laser on that smooth muscle. And because we're increasing the lymph flow downstream, as I've already mentioned, the lymph vessels or the lymph system generally will increase in capacity because it's been stimulated with that increase in downstream fluid. So one of the common questions I get asked is how safe is laser when we're talking of using laser in oncology forums. And of course, it's a very important conversation to have. Now, I'm not going to spend a lot of time on this because we just simply don't have the time. But this was one of the very first studies that was done by, some of you will know, Lisa Luxo and her team in 2010. Lisa's a physio in Queensland, and it's an in vitro study where it was really the first study that I know of that looked at breast cancer cells. in vitro, and they had 3 different cell lines, and they also used controls with fibroblasts. And they looked at different wavelengths of laser, and they really found overall that the laser was very safe. There wasn't an increased growth in the tumour cells, nor was there an increased growth in the normal epithelial cells. But they did find in one case with a 780 nanometre laser, it did have a slight proliferatory effect on the breast cancer cells, but interestingly not with the melanoma cancer cells. But when they did repeat doses with that 780, it was the opposite. It had a negative effect. So that was one of the very early studies that sort of started to talk about the safety of laser with breast cancer cells. But obviously more research needed to be done before we could safely say we were able to use laser, particularly over, surgical sites, etc., where tumours had been excised. So if we fast forward to 2019, now there was a systematic review done, and I think they used 27 studies, if I'm correct, where that met criteria, and they looked at all the effects of that currently PBM is used for, and whether there was any concerns with oncological safety. And they were looking at peripheral neuropathy, radiation dermatitis, lymphedema, oral mucositis, so a whole range of different studies. The conclusion was from that systematic review, based on what we know to date, is that PBM is safe in the use of cancer treatments and related toxicities. So that was quite encouraging as well. Then a lovely study that was actually done and using the MLS system. So, of course, very relevant tonight to mention this. They looked at 2 breast cancer cell lines and also a control cells of fibroblasts. They had 3 daily sessions of 9 joules per centimetre squared dosage, and they used a scan. They used the handpiece, and I think they were scanning over the cell lines at a speed of about 5 centimetres per second, I think it was. And none of those cell lines showed any proliferative effect with the laser. So again, a nice outcome. So I hope that gives you some confidence. We still don't treat over an active tumour site unless we have had a discussion with oncologists and it's in a palliative scenario, for example. And I have either a one-on-one discussion with the oncologist, or I get something in writing from the oncologist in those cases. But the laser can be very helpful for people in palliative care to just reduce the discomfort and that a tense, tight feeling that people will get in limbs. So we're not saying we don't use it, we just do it mindfully. And with a discussion with other relevant practitioners. So if we now look at the evidence for treating lymphedema per se, it really started with Lieven's work in 1990s, and I'll show you a nice picture in a minute around that. But the first work was done around wound healing. And our clinic in 1988 did an inaugural study following we'd been using laser for lymphedema. I think we were really the first place in the world to use it. And we then did a trial with Flinders, and then the first RCT was done in 2003 using a Rion-Core laser, which some of you would be familiar with that are already working in the laser world. So that study was an interesting one. It was only done through the armpit, and there were 17 points that were done in a grid pattern using a 1.5 joules per centimetre squared with this laser that you can see in the picture, which is a handheld 904 laser. Now, interestingly, they found that 2 cycles were more effective than 1 cycle, and a cycle was 3 times a week, and then there was a washout period of 3 weeks, and then they had another cycle. Now, the interesting thing was after 1 cycle of treatment, there was some improvement in volume, but it wasn't statistically significant. And they found with 2 cycles that interestingly, it was about a 3-month period post-treatment when they retested them, that I think 31% of those that received the laser compared to the control group that was placebo laser, 31% had a greater than 200 mil reduction. And that was 3 months after their treatment had been completed. So we were starting then to think, well, our cycle's better than regular 3 times a week treatment. And it started a conversation about really how we're using laser in different ways. So if we fast forward then to 2017, this was a systematic review done by Baxter, who's a physio in New Zealand, and 7 RCTs and 4 case study observational studies met the criteria. And they looked at PBM in a variety of different ways. It was compared to sham, massage, compression, and bandaging. A range of dosages were used between 1.5 and 2.4, but the most common dosage used was 1.5, and it was mainly over the axilla. So it was almost like that was following on from the karate study. We don't just do laser over the armpit, and I'll show you our protocols in a little while. So the conclusion from that was that there was strong evidence for PBM over sham laser to reduce limb volume, certainly in the short term, and moderate evidence to reduce pain. One of the studies that systematic review looked at, and I've included this is because it was one of the studies, we still don't really have enough information comparing PBM to our gold standard treatments of lymphedema management, which would be bandaging, MLD, which is manual lymphatic drainage. So we still don't have a lot of comparative studies of laser comparing our mainstays of treatment. But this study was quite interesting. It was only a small study, 46 people in total, but they did compare massage with laser. So they had a group that had 40 minutes of a massage, a group that had 40 minutes of massage plus 20 minutes of laser, and then a group that just had 20 minutes of laser. And interestingly, the group that had 20 minutes of laser showed that their volume reduction was as effective as massage. So it begs the question, is there an economic benefit to using laser over massage, which of course is quite resource rich, and most massages in a lymphedema setting last for about 45 minutes to an hour. So again, an interesting study. So how does laser affect inflammatory response? And this is an important thing to think about because it underpins so much of pathologies that we treat as therapists, including lymphedema. So I'll just whiz through these because I think you've probably discussed them in previous webinars, and I really want to get onto the protocols of how we use it. But in essence, it is an anti-inflammatory, and it has been shown to be as effective as NSAIDs in some studies. So it is a very powerful tool that we have at our disposal. And it really seems to have an effect on NF-kappa B, which is the master switch for inflammatory response, possibly through at a cell level because of the sudden increase in reactive oxygen species, and that somehow stimulates this inflammatory modulation. So I really think this is important because it does help us understand why laser can be very useful in the early stages of lymphedema and lymphatic vessel change. Now, there's probably not an immediate response with inflammatory change. It's probably more measured in hours rather than an immediate change. But the importance of lymphedema and inflammatory response is that there is a Th2 differentiation, which is just T cells differentiated. And it seems now from this study in 2017 that that is an important precursor to lymphatic vessel damage, that this inflammatory response in the early stages, even possibly before we see lymphedema, damages the vessel in some way, and it then leads into vessel damage, which probably then leads us into that domino effect of level 1, level 2 and staging of lymphedema. So my thought is that if we are starting with PBM early enough, can we mitigate some of these early lymphatic changes because we are having a modulating effect on that on that inflammatory response? And there have been studies that have used NSAIDs, and certainly that does change those early lymphatic changes, and it can actually even change the skin texture. A study done in the US has used ketoprofen to suggest that. So it's an important, again, conversation to have. So I say let there be light, or PBM to be exact. So PBM in relation to lymphedema, and we'll just have a quick look at that. It basically is an anti-inflammatory with specific effects on the fibrosis as well, probably through increasing phagocytosis with macrophage influx, and also an effect on the immune response, which is important when we look at cellulitis risk. And it, as I mentioned, it increases the motoricity of lymph vessels. So this is to show you the histological changes with laser. This is a lovely study, the slides on the left, of a study that was done at Flinders. Now, what they were trying to do was induce capsular contracture around a little implant in a mouse, because capsular contracture is a problem with silicone implants, and the silicone implants need to be taken out if this occurs. But you can see the slides on the left, which is the laser group, compared to the slides on the right. And if you look at the magnification below those slides, the slides on the left in the laser group show much more organised layers of connective tissue, less infiltrate compared to the slide on the right. And then if we go over to the slide on the far right, this is Leven's early work, and you can see a little lymph capillary, a venule and an arteriole, and they used red light over the tissue, and you can see the vessels underneath, how much bigger they are, up to about 50% increase in diameter, but also that there are more collateral pathways that you can see. So this is how we can stimulate and boost, if you like, the lymphatic capacity to shift fluid. Now, the side effects of PBM, I'm pleased to say, are few and far between. This is a list that's been compiled through research, but you can see none of them are really serious. We've already talked a little bit about the oncological safety, but I very rarely see, in reality, I very rarely see these side effects, but it is noteworthy to mention to your patients just in case they do exhibit some of these. They're very short-lived, less than 24 hours, and we are giving fairly low doses generally with lymphedema, about 1 to 2 joules certainly to begin with per centimetre squared. But if your patient does come to you and describe that they perhaps are migraineurs, that might be something to be aware of, that they might be have photo sensitivity. Or I've had one patient who had quite a nasty side effect to laser hair removal. She had diarrhoea for a couple of days, which we will never be sure that it was an effect of that, but it's something you might consider, and you might think, well, for my first dose, I'm going to do effectively a test dose and give a lower dose than you perhaps normally would. So let's get on to the nitty-gritty of it all. This is the arsenal of lasers that are currently being used in the lymphedema world. Most of those are from my clinic, and I'm not going to talk about all of them tonight. We just don't have time, but I think a lot of you would be using the Rearm Core handheld laser up in the left-hand corner. So I will use some of the examples compared to that, so you can just get a sense with how the MLS, the Morphe system, compares. So this is the Morphe system. You'd be very sure most of you would have seen these slides from previous webinars. The handheld one on the left, and then the Charlie head in the middle, and then, of course, the piece de resistance, the robotic head on the right. It's a unique patented system where 2 wavelengths are synchronised, and so you get an augmented effect in the wavelength emission. It penetrates about 3 to 4 centimetres, and you'll see in a little while how the protocols differ from other lasers. It's overall a much faster protocol because it's an augmented wavelength emission. So how do we treat lymphedema? Now, I'm just going to touch on some breast lymphedema and an evolving area head and neck lymphedema tonight. So the parameters that we need to think about firstly is that we don't need to penetrate very deeply. You've seen from the brief anatomy lesson that I gave you that the lymph vessels, certainly the initial, the superficial system, is very close to the surface of the skin. So we're penetrating well and truly the depth of that. So we don't need to do high doses for long periods of time with our dosages. We're generally treating whole limbs in my clinic. We're not just treating an axilla, for example, or in the case of a lower limb or groin. So our treatment sessions are generally about 45 minutes to an hour. They're generally treatments are longer than you would for your musculoskeletal conditions. And of course, musculoskeletal conditions generally have an endpoint, unless we're talking about chronicity and OA and conditions like that. So we're not, we can't say that 4 or 5 treatments of lasers and we've completed our treatment protocol. Lymphedema is managed, it's not cured. So generally our patients are for life. So our dosages, or our power dosages, if you like, are much lower sometimes than what you would see in musculoskeletal conditions, and generally they're less than 200 milliwatts per centimetre squared for those of you that are interested in those sort of parameters. And our lasers are generally on for minutes rather than seconds. However, with the MLS system, it is generally faster. And our dosages are initially about 1 to 4 joules per centimetre squared. So this is where we're going to start having a bit of a look at comparative dosages. So if we first look at our re-encore, how we get to our dosages, I won't really get into tonight, but it's basically a power density multiplied by the amount of time that you've got it on for. So our re-encore for a minute will often give us 1.5 joules per centimetre squared. So in 100 seconds, we're looking at 2.5 joules per centimetre squared. Now, if we compare that to our Morphe 6, which is the Charlie head, we're only having it on for 15 seconds because our power density is a lot more. So we don't need it on for as long. The Morphe handpiece, which is an energy density of 115 milliwatts per centimetre squared, I think that's at about 50% intensity for those that have units. For 18 seconds, we're getting what we would expect we would need for lymphedema management. So you can start to see here the differences between different units. Excuse me. The BioFlex unit, which some of you may be aware of, is a large probe that wraps around limbs, but it also comes with a single probe, which is a laser diode. And that's a single wavelength of 830, and we're giving very, very large energy densities there. So for 10 seconds, we're delivering 47 joules per centimetre squared. Not needed for lymphedema, but may be good for musculoskeletal conditions. So you can see there the difference that in different units. How often are we treating lymphedema is another common question I get asked, and we don't need to treat daily. Laser is a cumulative effect, so over a week or two, you're going to get the effects building up. So generally speaking, no PBM treatment really needs to be done daily. I like to think that there's a down day where, particularly if it's the effects are a bit delayed for several hours, your cells have time to react and increase their metabolic rate, which is what happens. So every second to third day for musculoskeletal conditions or for lymphedema, but fairly quickly we can stretch that out. And certainly in my clinic, we may see clients every 6 to 8 weeks once their lymphedema has become stabilised. So perhaps in a stage 1 lymphedema or a latent lymphedema, we won't need to see people as often because we're perhaps only wanting to measure them, monitor them, and perhaps have an effect on those early inflammatory stages, and perhaps then things will settle down. But compared to a stage 3 lymphedema, which you saw in that limb, which is quite fibrotic, there's redness, there's definitely low-grade inflammatory response, and the tissues won't respond as quickly. We may need to see them a couple of times a week more often. But be guided by, obviously, the response that your patients are feeding back to you, and it's generally not as often as you would treat a musculoskeletal condition. How do we assess lymphedema? Well, this is a really good question. There's lots of tools. But in essence, we use a range of things, photos, indurometers. I'm not going to go too much into this other than just describe quickly this moisture meter, which is a very useful tool. And I'll show you an example of what happens in lymphedema assessment with the laser. And then we also use that machine on the right, which is a SOZO machine, which measures the interstitial fluid volume through resistance to a current. But very important is subjective reporting, because basically your patients are going to come back and say, my arm feels lighter, often before there's volume change. And this a very interesting study is an example of that. It didn't show any volume reduction, but the symptoms of distress were significantly reduced. So I think we can get hung up on volume sometimes, when sometimes our patient's goal is to actually just have a more comfortable limb. So this shows you what happens in the moisture meter readings that we have taken in this person's limb. Now, a moisture meter reading is taken on both sides as a comparative reading, and the ratios are worked out. And any ratio where the affected over the unaffected is greater than 1.2 is indicative of laser. So you can see in this patient, the moisture meter ratios were greater than 1.2, but post-laser, they were certainly coming down. Now, this is immediately after laser. We don't always see this change. And you can see there the patient's readings on the right were certainly less than their affected limb. So that's one way of looking at it. This is a SOZO measurement where any measurement between -10 and +10 is generally a normal range within a SOZO measurement. So you can see this person started out with 45, which is quite a high reading, and after laser it dropped down to 42. Now, after 2 laser treatments, you can see there it had dropped down to 24. So I was doing immediate pre and post laser readings. We then didn't see her for 17 months. She lived in the country, but her surgeon urged her to come back because her symptoms were increasing a little. And you can see then on the date on the 4th of May there, we did 1 laser treatment. Her LDEX reading had gone up a little bit to 32, but interestingly not back to her original 45 reading. But after 1 treatment, it had dropped down to 11. So, you know, a really good response. So I think your body almost has a memory for laser, and sometimes we don't need to do it a lot before we get quite a good response. So the protocols for limb lymphedema are that we treat proximal to distal. We would spend more time on fibrotic areas. As I said, it's generally a 1 to 4 joules per centimetre squared, at least to begin with. It might be slightly higher if you're scanning off tissue because there may be a little bit of scatter. And think about your lymph territories. If you've got a forearm congestion, then you may want to spend more time on the cubital nodes. Just as with a lower limb, you may want to spend more time on the medial side of the knee, where there's quite a bottleneck of lymph vessels, and it's often an area that we'd like to access, or the popliteal nodes. So we may start off with 1 or 2 a week and then go to 6 weekly. Now, we use our anti-edema mode on our MLS systems. And you can see here, if you're doing a handheld laser, then that's equivalent of a 3 centimetre squared area. So you would adjust your settings on your machine to 3, adjust the hertz to 2000 hertz, and effectively over 18 seconds at 50%, you're getting the dose that you would need of 2.08 joules per centimetre squared. And the same if you're using your Charlie head, that's a 20 centimetre area, and you can see there how I've reached my dosage of around 3.8. So if you're treating the upper limb. And if we just have an example there of an upper limb quadrant, stage 1 lymphedema, with the handheld MLS, you might do 4 areas in the armpit, and then you would work distally. You might do sections through the trunk. We know through our ICG testing that the parasternal nodes are important, and they're, over the 2nd, 3rd, and 4th, 5th ribs generally. The supraclavicular area, which is above the clavicle, obviously, and then you may travel down and do some sections through the upper limb and the forearm. So this is really, with the MLS system, all those areas would be equivalent of about 6 to 8 minute treatment. So that's what it would look like if you were using a diagram. If we were treating a lower limb, this is what it would be. It's a very similar process. You work proximally from the groin nodes distally, and you would spend time more where there's congested areas. And again, it's about a 6 to 8 minute treatment, and that's what it would look like. If you were using a handpiece in scan mode, you might use a scan mode over a 5 centimetre by 5 centimetre area, if you prefer to do it that way. If you didn't want direct contact with the skin, then that would be a 25 centimetre squared area. And it's a very similar thing. You just adjust your parameters until you get around the dosage that you want, and that would be equivalent of about a 17-minute section. And that's what it would look like through a scan mode. If you were using treatment through the breast, remembering that the breast drains mainly to the axilla, but we are finding now through ICG that there is definitely an important element to the parasternal nodes. So now we treat the parasternal nodes as a matter of course. And it's exactly the same thing. If you divide your breast up into 4 quadrants, if you like, or pieces of the pie, you treat your supraclavicular or your axilla and your parasternal, and then you would spend a little bit of time in each quadrant of the breast. It's quite common for the breast lymphedema to probably gravitationally draw down to the inferior quadrants, and we certainly would be spending more time on those. And again, that's what it would look like if you were treating a breast. If, for example, we're comparing it to Rian core, if you remember that with the, if we go back to the MLS of about 3 minutes dosage with the handheld piece, with an Rian core, because the area of that handheld is so much smaller, you're doing more points, and 1 minute is equivalent of 1.5 joules per centimetre squared. So there's a lot more points, and effectively your treatment is longer. So I've just put that slide in so you can see how they compare. We're probably running out of time a little bit, but that's just an example of using the moisture meter over a breast area. And you can see that if you look at the upper left quadrant, 2.2 is definitely greater than 1.2 ratio. So we know there's swelling there. And then if you look at the next one on the right, the ratio decreases to 2.04, and then 1.68, 1.68, and 1.59. So that's just one way we can measure that our treatments are being effective. And that's just a very raw picture of one of our patients' real life diagrams. So I haven't tried to hide anything from you. If we just have a very quick look at head and neck lymphedema, and this is an evolving area, but there's a much greater risk of lymphedema in head and neck because it's a very lymphatic rich area. There's 300 lymph nodes in the head and neck, often if patients and in people, and about 30% of the whole total lymph nodes in someone's body is actually in the head and neck. So there's a much higher risk, and in some research it's claimed that there's probably an overall risk of about 90% chance of getting lymphedema or fibrosis in patients after some form of head and neck surgery. So it's a very big problem, and it manifests mainly in submental swelling. And you can see that photo on the right-hand side was of a case study that I helped out in, and it was just really discussing protocols with the therapist. And that was a very interesting case because you can see in a minute that had quite a profound effect on his scar as well. So photos are very useful because you're going to see subtle changes in head and neck lymphedema. That's again just to show you with where we would use the Morphe handpiece over a head and neck lymphedema, accessing the supraclavicular nodes, submental, and then following along the scar lines. That's in a unilateral dissection. Same dosages that we would use with LYM. And this is a palliative patient of mine. You can see she could not open her eyes at all. She had so much profound swelling, so she couldn't even find her way to the toilet. Her daughter had to become her carer, and you can see there over a 45-minute scanning laser treatment the significant difference that she had in her lymphedema. It made a huge difference to her in her last few weeks of life. So what should you do if treatment is not progressing? The first thing is to look at the frequency of your treatments. Are you treating often enough? Can you access more central pathways? We understand now a lot more about those from our ICG studies. Look at your dosage. You can increase your dosage. Don't be frightened of increasing your dosage. But also red flags. Be mindful that perhaps there's something else going on that we're not aware of, or perhaps there's an ADL influence. You know, perhaps somebody's babysitting their children more, or they've returned to the gym, and that's having an impact on their lymphedema. So just be mindful of asking the right sort of questions. And where are we heading? We're certainly heading in some very exciting areas, looking at laser prophylactically with external beam radiotherapy to ameliorate those effects of radiation dermatitis, and there's some excellent studies out there. Perhaps we're going to use it for chemo patients to reduce their brain fog. I was involved in a Parkinson's study last year where we were using helmets on patients and using intracranial laser. But one very fascinating area is over the gut to affect the gut microbiome. So, you know, we have very exciting ways of looking at laser now that we're not even sure of how we're dealing with it. But sorry, my computer in the background here is making some very strange noises. So I hope that's not coming through too loud for you. So treating the gut is going to be a very interesting way, and of course that a way of using laser that has really profound effects on chronic health issues, and they've even done a study around using COVID patients and the effects a PBM will have on long COVID in particular. This is the trial. I urge you to read this if you are a lymphedema therapist, and how it has an effect on radiation dermatitis, and that was again using an MLS laser over a radiation site for breast cancer. And a lovely study done in 2016 where a panel of radiation oncologists and specialist dermatologists came together and found through research and their own clinical protocols what the best protocols were for using laser both prophylactically and therapeutically for head and neck cancer patients in chemoradiation. And I love this picture. I never get sick of looking at it. It was basically from a book published by Turner and Hode many years ago now, but it was just using scanning laser over 3 treatments, and you can see the very profound effect it has on that patient, and it's taken us so long to get to this conversation of how we're going to use it for chemoradiation, but we're almost there. And again, for oral mucositis, I urge you to look at this website. It's a recommended treatment in some parts of the world now to prevent oral mucositis, because it is a very difficult thing to treat once it's there, and laser has proven to be a really robust way of using it to prevent oral mucositis. So I'm sorry we had to rush a little bit towards the end. I never quite know how my timing's going to go, but I thank you very much for being with us tonight. I hope that's given you a little bit of insight in how you can use your laser for lymphedema, and I'll hand back to Catherine now in case there are some questions.
Great, thank you very much, Sharon. That was terrific. Can you unshare your video? There we go. Okay, great. Okay, here we go. Thank you so much. Yes, that was a lot of material covered, wasn't it, in a really short amount of time? And
Still
we've
dancing for lasers.
Yeah, listen, thanks very much, Sharon, because I know you've had a big week at work right now, and today's even been a big day at work again for you. So appreciate you taking the time to do this for us. We've got some questions. Can I just ask a few of these? Whatever ones we don't get time for, I will send them out afterwards. I'll follow up with you. But we had a couple of comments about audio, so I hope everybody got to satisfactorily hear this. Just want to ask, someone wanted a copy of the presentation. Let me say, we're going to make this available via audio for a couple of weeks, but due to confidentiality, these slides are not available. However, we will send you some information about other future courses that Sharon's teaching, so you can have access that way. So let me see here. We've got a question here. I have a client with a Morel-Lavelle lesion, the size of a golf ball on the site of a total hip replacement. That's all it says.
Okay, I'm not familiar with that lesion. I don't know if it's an ulcer, but generally when we're using PBM for wound management, if it's an open lesion, you wouldn't do it in direct contact. You would be using probably an off-contact scan, or just hold the handpiece off-site, and you would be using much lower dosages. So it's a slightly different protocol to what we would use for lymphedema.
Okay, thank you. And there's a question here, awesome content. Thank you, Sharon, that's the comment. How many public health lymphedema clinics in Australia now offer PBM, do you think?
It's a great question. Because in South Australia we have been very proactively using laser for quite some time, there are now there's one public hospital I know of that has laser units now. I've certainly done training in Queensland. The hospital, Women's Hospital up in Queensland, have 2 scanning lasers. It's not common practice because they still are, quite expensive, and they are resource rich, but it's an evolving practice. So I can't really tell you. I know that in some states it's being, the use is more prevalent than others. New South Wales seems to be a bit slower on the uptake with laser in public spaces, but certainly in South Australia we're probably punching above our weight.
Okay, sounds great. Hi, Sharon, great talk. Thank you very much. What is the dose intensity with the HandiCure handheld unit for treatment for lymphedema?
It's a great question. We actually don't know. I've had a engineer dismantle one of mine, and it's a bit of a guesstimation. So I can perhaps, if you want to contact me privately through Catherine, I can give you a little bit more information. But we're probably, with about 5 minutes worth of HandiCure, we're probably delivering around about the right dosage. But we don't have strong information from the manufacturers on the power density, so we just don't know.
Okay. Hi, Sharon. I haven't used laser before. Can you direct me to some training?
Yeah, well, it depends. I haven't talked about this, but in Australia, if you're using laser in some states, you need to do an accredited laser safety course. Queensland, Tasmania, WA, and our B.Ap.Sc association run an accredited course a couple of times a year. So Catherine can probably direct you to that. So that's necessary in those states. I am involved with some training online through a private lymphedema company, education company, which I can put you in contact with. And that's a series of 3 webinars, which goes through laser safety introduction, then limb lymphedema, head and neck lymphedema, breast lymphedema, in more expanded version. And then we also talk about musculoskeletal related lasers. So you could perhaps get in contact with Catherine, who's also.
So what I'll do, Sharon, is I'll put some links into to AMPA and into those courses, so you can access them in our follow-up email, so that way they can find out more about them directly.
Right.
Let me see. What is the total dose for upper limb? I know that's a hard.
Well, we don't really talk about total dose. It's not really important. It's more about the where you're delivering at what area of the limb. But in essence, we're probably delivering up to 20 joules per centimetre squared in a cumulative dose, if you want to look at it that way. Some with cording, perhaps it's not that much because we're just using it through the axilla. I haven't talked about cording tonight, but those lymphedema therapists out there will know what I mean. So it's certainly not, it's certainly nothing to be concerned about. The cumulative dose of laser is not a conversation we really have anymore.
Okay, now Sharon, the number of questions is going up and up and up as we're here talking.
Well, I've got a few minutes, but I don't. That's fine if you want to keep going. It's up to you, really.
No, I'll just run through as many as we can, but just quickly,
Okay.
Just so you can get a sense of what they are. Would you use low-level laser therapy as a standalone treatment for limb lymphedema or in conjunction with compression?
Very good question. No, laser is one tool in our toolbox, but having said that, we do have some patients that for some reason can't don garments. There's a whole range of different, we could speak for hours on this topic, but we do have some clients that do come in just for laser, yes, and it's because it reduces their limb discomfort, sometimes their volume, independent of other things.
Okay, another comment here, so helpful, been fantastic tonight. Thank you so much, Sharon. And this one we may not be able to answer quickly, but has there been any studies on laser use on radiation fibrosis longer term after head and neck cancer treatment?
Excellent question. Not long term, no. It's on the acute effects of radiation. There's a little bit around scarring, which I guess is relevant, which we haven't talked about tonight. And those studies have tended to be, the studies around radiation dermatitis have been short-term studies, so they haven't followed up those patients. The transdermis trial, I can't remember, I think they were really only monitoring them for a few months after their radiation. There is one study that looked at radiation ulceration after, these are ulcers that weren't healing for 5 years. It's a Schaefer study. I can perhaps put you in touch with it. And they had resolution of those long-term ulceration problems. So I think I think the laser is effective. It's just that we haven't done the research.
And we have put together some research articles, a summary of some research articles that might be of interest to people. We'll send those out after this webinar as well. Okay, just one or two quick more questions. What are the absolute contraindications?
Laser? Over a malignancy that hasn't been excised or had radiotherapy or chemo, we wouldn't do it over a lesion. We would treat remotely, absolutely, but not directly over a lesion. Over pregnant, what we would term a pregnant uterus, and that's not because it's dangerous, because we just don't. In fact, they've done some rat studies, and the baby rats were actually bigger and healthier in had laser. But my daughter's pregnant at the moment, and I think she would freak if I told her I was going to laser her. So really, in the oncological world, it's really that the tumour. There's very, very few contraindications. We used to talk about over the thyroid. We don't talk about that anymore. Mm-hmm. Safe over implants, breast implants. I hope that answers your question.
Yep, that's fantastic. And there's certainly a lot of research, a lot of articles out there about contraindications as well, yes, that people can easily access. What dosage do you use for capsular contracture and tissue expander reconstructed breast?
Well, that's such a great question. I think we need to go slightly higher and probably more frequent treatments as well. I've managed to stave off surgery with a couple of clients of having to have their implants, their revision surgery done. and I'd still start off with somewhere around 2 to 3 joules per centimetre squared, but I certainly wouldn't be frightened to go up to 8 joules per centimetre squared. And I think you probably at least initially need to treat a couple of times a week.
Okay. All right. I think we'll wrap it up there. There's a couple of questions here about how can people get more skilled in this. We'll send out information about education programs. And again, many thanks for a fabulous webinar. A lot of thanks coming in for you tonight, Sharon. So I know.
The love.
Yeah, that's right. That's right. Sharing it around. I'll go through these questions and I'll identify some of the key ones that come out, and we'll follow up with an answer we'll send out a couple of emails after this as a follow-up. So listen, Thank you very much for your time tonight. I know it's a big week for you, but we really appreciate it, and you've had a far-reaching impact.
That's wonderful. That's our intention.
Okay. Thanks so much, Sharon. Appreciate it.
Bye.
Bye. Bye-bye, everyone. Thank you.